Hi everyone, this is our first cardiology lecture in the series of 4 lectures for Pharmacology 2. Our focus for today is hemodynamics and risk reduction, specifically hypertension, hypotension, and lipid disorders. This week you'll find aligns very well with the clinical medicine content as you begin EKG fundamentals, hypertension evaluation, hypotension physiology and lipid. We will build in the pharmacology foundation that supports those disease processes. So as we go through today's lecture, again, we're not always trying to just memorize drug classes. We want to understand how these medications work mechanistically in the body to modify cardiac output, systemic vascular resistance, the renin-angiotensin-aldosterone system, and the long-term atherosclerotic risk. So by the end of today's lecture, you should be able to explain not only what each drug does, but why you would select it in a specific cardiovascular condition. Okay, and the next 2 slides here are our instructional objectives. These instructional objectives carry through the entire cardiology series of 4 lectures for pharmacology. And then for each lecture, I've just kind of organized the material to align with what you're covering in your clinical medicine course. So I won't read these to you, but again, these are the same instructional objectives for every pharmacology lecture in the cardiology series. And here we have instructional objectives continued. So again, when we are looking at today's lecture, we're lining up with your clinical medicine topics for the week. So EKG fundamentals, and then 3 high-frequency cardiovascular problem areas, which is hypertension, hypotension, and lipid disorders. First, we'll emphasize regulation of vascular tone. That means understanding how medications can change systemic vascular resistance, primarily through the sympathetic system, the RAAS, and direct vascular smooth muscle effects. This directly supports your hypertension and hypotension decision making. Second, we'll focus on cardiac output modulation. This is where agents like beta blockers and pressors matter because they are going to change heart rate, contractility, and overall perfusion. This also connects with EKG fundamentals because many of these agents impact the conduction and rhythm. And then third, we'll cover the ASCVD risk reduction, which centers on lipid-lowering therapy. The pharmacology here is all about reducing LDL and triglycerides to reduce future cardiovascular events. And as you know and you're learning, this is a major theme in primary care and also a recurring theme on the PANCE. So before we talk about drug classes, we need a physiologic anchor. So blood pressure is determined by cardiac output multiplied by systemic vascular resistance. So every antihypertensive or pressor you will learn this week changes one or both of these variables. Cardiac output is determined by heart rate and stroke volume. Systemic vascular resistance is determined by arterial tone. There are 4 major therapeutic targets that medications use to modify blood pressure. For the sympathetic nervous systems, drugs that block beta receptors or alpha receptors reduce heart rate, contractility, and vasoconstriction. Second, the renin-angiotensin-aldosterone system. ACE inhibitors and ARBs interrupt this pathway to reduce vasoconstriction and sodium retention. And third, renal sodium and water balance. Diuretics reduce intravascular volume, which lowers cardiac output initially, and systemic resistance over time is reduced. And then fourth, vascular smooth muscle tone. Calcium channel blockers and direct vasodilators reduce arterial constriction. So as we move through each drug, I want you to continually ask, is this drug changing cardiac output, systemic vascular resistance, or both? And as you choose these questions, this will help you choose the correct medication clinically. Okay, so this slide is foundational, and you'll find that if you can really get this part of the adrenergic receptors memorized, the rest of pharmacology in cardiology will come very logically. So alpha-1 receptors are located primarily on vascular smooth muscle. When stimulated, they cause vasoconstriction, and this increases vascular systemic resistance. So any drug that activates alpha-1 will raise blood pressure. Any drug that blocks alpha-1 will lower it. Beta-1 receptors are located primarily in the heart and the juxtaglomerular cells of the kidney. Stimulation of beta 1 receptors increases heart rate, increases contractility, and increases renin release. Blocking beta 1 lowers heart rate, lowers contractility, and reduces RAAS activation. Beta 2 receptors cause vasodilation and bronchodilation. This is important when we talk about non-selective beta blockers because blocking beta 2 can provoke bronchospasm. And then D1 receptors primarily cause renal vasodilation. This becomes relevant when we discuss dopamine and dose-dependent receptor activity. So when you're evaluating pressors and beta blockers, you always want to ask which receptor is this targeting. Okay, so talking specifically about our antihypertensives. ACE inhibitors are our first medication, and they are one of the most important cardiovascular drug classes you will use in practice. Mechanicalistically, they block the conversion of angiotensin 1 to angiotensin 2. This decreases vasoconstriction and decreases aldosterone secretion, which lowers sodium and water retention. Because they also increase bradykinin levels, this contributes to vasodilation, but also explains the dry cough, which is a very common side effect. Therapeutically, ACE inhibitors are first line for hypertension. They are especially important in patients with chronic kidney disease with proteinuria. They are foundational in heart failure and after myocardial infarction because they reduce pathologic ventricular remodeling. And importantly, they provide mortality benefit in cardiovascular disease. ACE inhibitors are administered orally. Some of our common adverse effects, one of the most common is a dry cough. Others include hyperkalemia due to reduced aldosterone, hypotension, particularly after the first dose, and a mild increase in creatinine level. A small creatinine rise is expected because of the work the ACE inhibitors are doing on the kidney, but you do want to monitor the kidney function. Serious adverse effect is angioedema, and then contraindications are pregnancy, bilateral renal artery stenosis, and in patients with prior ACE-induced angioedema, of course. And then clinically, if a patient has hypertension plus diabetes or chronic kidney disease, an ACE inhibitor is often an appropriate first choice because of the renal and cardiovascular protective effects. And just remember, they do show mortality benefit in cardiovascular disease. Moving on to ARBs, or angiotensin receptor blockers. These work slightly downstream from ACE inhibitors. So instead of blocking the conversion of angiotensin 1 to angiotensin 2, they block the angiotensin 1 receptor. And this prevents angiotensin 2 from exerting its vasoconstrictive and aldosterone stimulating effects. Therapeutically, ARBs are used in hypertension, heart failure, and chronic kidney disease, essentially the same clinical settings as your ACE inhibitors. ARBs are administered orally. So the adverse effect profile of ARBs overlaps with ACE inhibitors, particularly hyperkalemia and renal dysfunction due to reduced aldosterone activity and efferent arterial dilation. So you want to make sure you're monitoring kidney function. They also share the same contraindications, pregnancy and bilateral renal artery stenosis. The key differentiation is that ARBs do not increase bradykinin levels. That means they are much less likely to cause that dry cough. So clinically, if a patient develops ACE inhibitor-induced cough, an ARB is often an appropriate alternative to change the patient to. From a mortality standpoint, ARBs also provide cardiovascular protection, although ACE inhibitors are typically first line unless they are not tolerated. Okay, moving on to calcium channel blockers. Calcium channel blockers work by blocking the L-type calcium channel, so just like what it says in the name. These channels are responsible for calcium influx into the vascular smooth muscle and cardiac myocytes. When calcium entry is reduced, smooth muscle relaxation occurs, leading to vasodilation. In the heart, calcium channel blockers can decrease contractility and slow conduction through the AV node. There are two major classes that you will need to differentiate. Dihydropyridines primarily act on vascular smooth muscle, Their main effect is vasodilation and reduction in systemic vascular resistance. The other class is the non-dihydropyrimidines. They act more significantly on the cardiac tissue, so they decrease AV node conduction and reduce myocardial contractility. For week 1, the key is to recognize that calcium channel blockers reduce systemic vascular resistance and are used in hypertension. Later in week 3, we will revisit non-dihydropyrimidines in more detail when we cover rate control in arrhythmias. All of the commonly used agents in this class are administered orally in outpatient hypertension management. And then next, we're going to differentiate the dihydropyrimidine agents specifically. So as we said, the dihydropyrimidine calcium channel blockers primarily act on vascular smooth muscle. Their main effect is vasodilation, which lowers systemic vascular resistance. Because systemic vascular resistance is one of the 2 determinants of blood pressure, this makes them very effective antihypertensive agents. They are commonly used in hypertension and also in stable angina because reducing afterload decreases the myocardial oxygen demand. One important adverse effect is peripheral edema. This occurs due to preferential arterial dilation without equivalent venous dilation, leading to increased capillary hydrostatic pressure. So you want to remember, if you see a patient that has recently started a calcium channel blocker and now has edema, we want to think about that as a potential side effect. Another adverse effect that can be seen is reflex tachycardia, because sudden vasodilation activates the sympathetic nervous system and causes heart rate to increase reflexively. The primary contraindication is severe hypotension, since these agents further reduce vascular resistance. Clinically, if a patient has hypertension without significant conduction abnormalities, a dihydropyrimidine calcium channel blocker is often a reasonable first-line or add-on agent, particularly when vasodilation is desired without significant effects on heart rate. So our non-dihydropyridine calcium channel blockers differ significantly from the dihydropyridine class. Their primary effect is on cardiac tissue rather than vascular smooth muscle. They decrease AV node conduction and decrease myocardial contractility. Because of this, they lower the heart rate and reduce cardiac output in addition to lowering blood pressure. They are used in hypertension, but they are particularly important in rate control, which we will revisit in the coming weeks when we discuss arrhythmias. The adverse effects are predictable based on the mechanism. Bradycardia occurs due to AV node suppression. AV block can occur in susceptible patients, and constipation is also particularly common with certain agents. They are contraindicated in patients with heart failure with reduced ejection fraction because reduced contractility can worsen systolic dysfunction. They're also contraindicated in patients with significant heart block. Clinically, if a patient has hypertension and tachyarrhythmia, a non-dihydropyrimidine may be appropriate. But if a patient has systolic heart failure, this class should be avoided. Thiazide diuretics are one of the most important first-line agents for hypertension. Mechanicalistically, they block the sodium chloride transporter in the distal convoluted tubule. This increases sodium and water excretion, which initially lowers intravascular volume and cardiac output. Over time, they also reduce systemic vascular resistance, which helps sustain that blood pressure control. These agents are administered orally and commonly used in outpatient hypertension management. So you will see the thiazide diuretics as first-line therapy for hypertension in many guideline-based treatment algorithms because of there's strong outcome data that supports their ability to reduce cardiovascular events. Adverse effects reflect their impact on electrolyte balance. So hypokalemia is common. Hyponatremia can occur, particularly in older adults. Hyperuricemia may precipitate gout, and hyperglycemia can occur due to the effects on insulin sensitivity. Thiazide diuretics are contraindicated in severe renal impairment because they become ineffective when kidney function declines significantly. Clinically, thiazides are often selected early in treatment, especially in patients with uncomplicated hypertension and preserved renal function. Okay, so looking at loop diuretics, these are significantly more potent than our thiazide diuretics. They work by blocking the sodium-potassium 2-chloride transporter in the thick ascending limb of the loop of Henle in the kidney. This segment normally resorbs a large percentage of filtered sodium, so blocking it results in substantial diuresis. Because of this potency, loop diuretics are not typically first line for uncomplicated hypertension. Instead, you will see them used when volume overload is present, such as heart failure or pulmonary edema. These medications can be administered orally in outpatient management, but they are also available IV, which makes them especially useful in the acute setting like pulmonary edema. Adverse effects reflect their strong diuretic action. So hypokalemia is common and can be clinically significant. Dehydration and volume depletion can occur if over-diuresed. Ototoxicity is a unique and notable risk, especially with high doses or rapid IV administration. So clinically, when you think volume overload, particularly with pulmonary congestion, loop diuretics are often the appropriate choice due to their potency and IV availability. Okay, so another class of diuretic is our potassium-sparing diuretics, and mechanicalistically, these are distinct from thiazide and loop diuretics. They either antagonize aldosterone receptors or inhibit epithelial sodium channels, also known as ENAC channels in the distal nephron. By blocking aldosterone effects or sodium resorption at the final segment, they reduce sodium retention while preserving potassium. So because they are relatively weak diuretics, they are typically not used alone as first-line agents for hypertension. Instead, they are often added in cases of resistant hypertension or when hyperaldosteronism is present. This class is administered orally. The most important adverse effect is hyperkalemia, which makes a lot of sense as these are potassium sparing. Since they reduce the potassium excretion, potassium levels must be monitored closely, especially in patients who are also taking ACE inhibitors or ARBs, as we know that's an overlapping adverse effect. They are contraindicated in patients with renal failure or baseline hyperkalemia because of the risk of dangerous potassium elevation. Clinically, when you see resistant hypertension, particularly in the setting of suspected aldosterone excess, this class becomes especially relevant. So beta blockers reduce blood pressure by primarily lowering cardiac output and suppressing renin release. Mechanicalistically, they block beta-1 receptors in the heart and the kidney. Blocking beta-1 receptors reduces heart rate and contractility, which lowers cardiac output. Blocking beta-1 receptors in the juxtaglomerular cells decreases renin release, which reduces the RAAS activation. Some beta blockers will also block beta-2 receptors, which can affect the bronchial smooth muscle and peripheral vasculature. That distinction is clinically important, of course, based on your patient's past medical history. How do we use these? Beta blockers are used in hypertension, although they are not universally first line in uncomplicated cases. They are particularly important in patients with angina and in post-myocardial infarction because they reduce myocardial oxygen demand and they improve survival after myocardial infarction. They are available orally for outpatient management and IV in certain acute settings. So clinically, if a patient has hypertension plus coronary artery disease or recent MI, beta blockers are often strongly indicated due to their mortality benefit and anti-ischemic effects. The adverse effects of beta blockers are predictable, again, based on their mechanism. So bradycardia occurs because beta-1 blockade slows the SA and AV nodes. Fatigue is common and often related to reduced cardiac output and sympathetic tone. Depression has been reported and may be related to the central nervous system penetration of certain agents. Bronchospasm is particularly important with non-selective beta blockers that block beta-2 receptors. Since we know that beta-2 receptors mediate bronchodilation, blocking them can precipitate bronchospasm in patients with asthma or reactive airway disease. Major contraindications include severe bradycardia and significant AV block because further suppression of that conduction causes hemodynamic instability. Non-selective beta blockers are contraindicated in severe asthma due to the risk of bronchospasm. An important teaching point is to avoid abrupt discontinuation of beta blockers. Sudden withdrawal can lead to rebound sympathetic activity, resulting in tachycardia, hypertension, and even ischemia. Clinically, always assess baseline heart rate, conduction status, pulmonary history before initiating a beta blocker. So our alpha-1 blockers work by blocking alpha-1 receptors on vascular smooth muscle. When alpha-1 receptors are blocked, vasoconstriction is reduced, leading to peripheral vasodilation and decreased systemic vascular resistance. Because systemic vascular resistance is a major determinant of blood pressure, this lowers blood pressure. These agents are administered orally. They are generally used as adjunct therapy for hypertension rather than first-line treatment. Outcome trials have shown that they do not reduce cardiovascular events as effectively as other first-line classes such as thiazides, ACE inhibitors, ARBs, or calcium channel blockers. And so that explains why they are not typically first-line therapy. The primary adverse effects are orthostatic hypertension and syncope because they cause that vasodilation, particularly with the first dose. Patients can experience a significant drop in blood pressure when they're standing. So clinically, these agents may be considered when additional blood pressure control is needed, but they are not preferred as initial therapy due to that outcome data. Direct vasodilators do exactly what they sound like. They act directly on vascular smooth muscle rather than through receptor blockade. Their mechanism is direct arteriolar relaxation, which significantly reduces systemic vascular resistance. Because they act at the level of the arteriole, they primarily reduce afterload. These agents are typically reserved for resistant hypertension, meaning blood pressure that remains uncontrollable despite the use of multiple first-line agents. Some of these are available orally for outpatient, and certain agents are used inpatient via IV. Adverse effects are directly related to the mechanism. Rapid vasodilation can trigger reflex sympathetic activation, leading to reflex tachycardia. They can also cause fluid retention due to compensatory RAAS activation. Because of these compensatory effects, they are not to be used alone. So they require co-therapy with a beta blocker to control that reflex tachycardia and a diuretic to manage fluid retention. So clinically, we need to know these agents, but remember that they are considered later line options when standard therapies are insufficient. Nitrates work through nitric oxide mediated vasodilation. Nitric oxide increases cyclic GMP in vascular smooth muscle, leading primarily to venodilation. Because they dilate veins more than arteries, they reduce preload, meaning they decrease venous return to the heart. Reducing preload lowers myocardial wall stress and decreases oxygen demand, which explains their use in angina. They are also used in hypertensive emergencies in the IV form due to their rapid vasodilatory effect. There are several routes that nitrates can be given. They can be administered sublingually, which I know we have used as an example for many of the pharmacodynamic bioavailability options. So sublingually, they provide rapid relief. Orally, they are given for longer term management, and IV in acute care settings, but they also can be given transdermally for a more sustained effect. Common adverse effects include headache due to vasodilation and hypotension. One contraindication that is very important is concurrent use of phosphodiesterase 5 inhibitors. Combining these can cause profound hypotension due to excessive vasodilation. So when you think of preload reduction and angina relief, nitrates are going to be your key agent. Okay, so that's our overview of our hypertensive management classes, and now we're going to go to our hypotension management. So the goal in hypotension and shock states is to restore mean arterial pressure, or MAP, to maintain organ perfusion. So remember the equation: mean arterial pressure equals cardiac output times systemic vascular resistance. So pressors are going to work by increasing one or both of those variables. They may increase contractility, which increases stroke volume and cardiac output. They may increase heart rate, which also increases cardiac output, or they may increase systemic vascular resistance through vasoconstriction. Most pressors work through adrenergic receptor stimulation, although vasopressin works through a different receptor system that we'll discuss shortly. All the pressors are going to be administered intravenously because they require rapid titration and continuous monitoring in acute settings. So clinically, when evaluating hypotension, you want to ask if the problem is low cardiac output, low systemic vascular resistance, or both, and that will help guide your pressor selection. So dopamine is a classic example of dose-dependent receptor selectivity. At low doses, dopamine primarily stimulates D1 receptors, which cause renal vasodilation. Historically, this was thought to improve renal perfusion, although its clinical utility for renal protection has not been supported in the outcome data. At moderate doses, dopamine stimulates beta-1 receptors. So this is going to increase heart rate and contractility, thereby increasing cardiac output. At high doses, dopamine stimulates alpha-1 receptors, leading to vasoconstriction and increased systemic vascular resistance. So depending on the dose, dopamine can increase cardiac output, systemic vascular resistance, or both. It is used in hypotensive states when augmentation of cardiac output or vascular tone is needed. Primary adverse effect is tachyarrhythmia, particularly at high doses due to beta-1 stimulation. Clinically, dopamine is less commonly first line in many shock states today, but understanding its dose-dependent receptor profile is high yield for exams, as it reinforces some of that receptor physiology we talked about early in the course. Dobutamine is primarily a beta-1 agonist. Unlike dopamine, it does not have significant dose-dependent alpha effects. Its main action is increasing myocardial contractility through beta-1 receptor stimulation. It also mildly increases heart rate. Because of this mechanism, dobutamine primarily increases cardiac output rather than systemic vascular resistance. Clinically, it is used in low cardiac output states, particularly when the primary issue is poor forward flow rather than vasodilation. For example, in cardiogenic shock, improving contractility may be the key goal. This is administered intravenously in monitored settings. The main adverse effect is, again, that tachycardia and arrhythmia due to beta-1 stimulation. Increasing myocardial oxygen demand can also be a concern with patients with history of ischemia. When choosing between pressors, you want to remember if the problem is low contractility and low cardiac output, a beta-1 dominant agent like dobutamine may be more appropriate. So phenylephrine is a pure alpha-1 agonist. Because it selectively stimulates alpha-1 receptors on vascular smooth muscle, its primary effect is vasoconstriction. This increases systemic vascular resistance and raises blood pressure. Unlike agents with beta activity, phenylephrine does not directly increase heart rate or contractility. Because it increases systemic vascular resistance and blood pressure, the baroreceptor reflex may trigger reflex bradycardia. So you can actually see a decrease in heart rate in response to increase in blood pressure. Clinically, phenylephrine is used in hypotensive states where increasing vascular tone is the primary goal. It is useful when tachycardia is already present and further beta stimulation would be undesirable. Because it has no beta-2 activity, it does not cause bronchodilation. When selecting a pressor, again, you're going to ask, is the problem low vascular tone? If the answer is yes, then a pure alpha-1 agent like phenylephrine may be appropriate. So moving on to norepinephrine. Norepinephrine has strong alpha-1 activity and some beta-1 activity. The alpha-1 effect predominates, meaning its primary action is vasoconstriction and increased systemic vascular resistance. However, there is some beta-1 activity which also increases contractility and to a lesser extent heart rate. Because of this mixed activity, norepinephrine increases both systemic vascular resistance and cardiac output, although again, the dominant effect is vasoconstriction. It is used in severe hypotension, particularly when both vascular tone and perfusion need to be restored. The major adverse effects are arrhythmias due to beta-1 stimulation and ischemia due to intense vasoconstriction. Peripheral ischemia can also occur if vasoconstriction is excessive. So clinically, when the primary issue is profound hypotension with systemic vasodilation, norepinephrine's strong alpha-1 effect makes it a powerful option. When comparing to phenylephrine, remember phenylephrine is pure alpha-1. Norepinephrine is alpha-1 dominant, but also provides beta-1 support. So moving on to epinephrine, this stimulates alpha-1, beta-1, and beta-2 receptors. Because of the broad receptor activity, we would expect it to have complex hemodynamic effects. So alpha-1 stimulation increases systemic vascular resistance. Beta-1 stimulation increases heart rate and contractility, and beta-2 stimulation causes bronchodilation and some vasodilation in skeletal muscle. Clinically, epinephrine is used in severe hypotension when both cardiac output and vascular tone support are needed. It is also central to anaphylaxis management because the beta-2 effects relieve bronchospasm, while alpha-1 effects counteract vasodilation. Because of the strong beta-1 stimulation, tachycardia and arrhythmias are common adverse effects. Myocardial oxygen demand also increases, which can be problematic in ischemic patients. When comparing your pressors, epinephrine has the broadest receptor activity. Remember, it increases heart rate, contractility, vascular tone, and bronchodilation all simultaneously. Isoproterenol is a pure beta agonist with activity in both beta-1 and beta-2 receptors. Because it lacks alpha-1 activity, it does not cause vasoconstriction. Beta-1 stimulation leads to increased heart rate and increased contractility. Beta-2 stimulation leads to vasodilation and bronchodilation. The combined effect is significant tachycardia along with decreased systemic vascular resistance due to beta-2 mediated vasodilation. Clinically, because it lowers systemic vascular resistance, it is not typically used when vasoconstriction is required to support the blood pressure. Instead, its physiologic effects are more relevant in specific Brady arrhythmic or conduction-related contexts, which we will revisit later. The key teaching point is receptor logic. There is no alpha-1 activity, thus there will be no direct vasoconstriction. So compared to epinephrine and norepinephrine, isoproterenol lacks alpha effects and therefore produces very different hemodynamic profile. Vasopressin differs from the previous pressors because it does not work through adrenergic receptors. Instead, it acts on V1 receptors located in the vascular smooth muscle. Activation of V1 receptors causes vasoconstriction. Because its mechanism is independent of alpha and beta receptors, it can be effective when adrenergic receptors are downregulated or when high-dose catecholamines are no longer producing significant response. So its primary effect is increasing systemic vascular resistance, does not increase heart rate or contractility. Clinically, vasopressin is often used when catecholamines are insufficient to restore blood pressure. Its distinct receptor pathway allows it to provide additional vasoconstriction without relying on alpha-1 stimulation. When comparing all of your pressors, you're going to remember that dopamine, norepinephrine, epinephrine, phenylephrine, and isoproterenol all act through adrenergic receptors. Vasopressin acts through V1 receptors and is mechanicalistically distinct. And this is basically the end of the pressor agents. Keep in mind, we'll revisit pressors again when we do shock in the emergency medicine series, but this is your introduction as it does fall into the cardiac medications we need to cover. Okay, moving on to lipid-lowering therapy and ASCVD risk reduction. Okay, statins are, of course, foundational in lipid-lowering therapy and atherosclerotic cardiovascular disease risk reduction. Mechanicalistically, they inhibit HMG-CoA reductase, the rate-limiting enzyme in hepatic cholesterol synthesis. When hepatic cholesterol production decreases, the liver upregulates LDL receptors, which increases clearance of LDL from the bloodstream. The primary clinical use is both primary prevention and secondary prevention of atherosclerotic cardiovascular disease. In other words, statins are used to prevent first events and prevent recurrent events. Statins are administered orally. Common adverse effects of statins include myopathy, an elevation in liver transaminases. Severe muscle injury is rare but important to recognize. Statins are contraindicated in active liver disease and pregnancy. The most important clinical point on this slide is that statins are the only lipid-lowering class with strong mortality benefit in cardiovascular disease. So that makes them first-line therapy in patients with elevated ASCVD risk. When you think lipid management, statins are going to be your anchor therapy. Ezetimibe works in a completely different mechanism than statins. Instead of inhibiting cholesterol synthesis in the liver, ezetimibe inhibits intestinal cholesterol absorption. So by blocking absorption at the brush border of the small intestine, less dietary and biliary cholesterol enters the circulation. Because of this mechanism, ezetimibe lowers LDL but does not have the same magnitude of LDL reduction as high-intensity statins. Ezetimibe is administered orally. It's generally well tolerated with few significant adverse effects compared to other lipid-lowering agents. Clinically, you would see this agent used as adjunct therapy when additional LDL reduction is needed beyond what a statin has provided, or if a patient is unable to tolerate a high-intensity statin. So our key distinction to remember is that our statins reduce cholesterol synthesis and ezetimibe reduces cholesterol absorption. Bile acid sequestrants lower LDL cholesterol through through a GI mechanism. So they bind bile acids in the intestine and prevent their reabsorption. Normally, bile acids are recycled through enterohepatic circulation. When they are bound and excreted, the liver must use cholesterol to synthesize new bile acids. As hepatic cholesterol stores decrease, LDL receptors are upregulated, leading to increased LDL clearance from the bloodstream. These medications are administered orally. Most common adverse effects are GI, including bloating and constipation, because the agents remain in the GI tract and bind substances non-specifically. They can also bind other medications and reduce their absorption. So this would be a potential drug-drug interaction. Clinically, bile acid sequestrants may be used for LDL lowering, but they are not generally first line due to tolerability and drug interaction issues. So again, continuing on our key mechanisms of action distinctions. Statins are going to decrease synthesis. Ezetimibe decreases absorption. Bile acid sequestrants increase bile acid excretion to drive LDL clearance. Fibric acid derivatives primarily target triglycerides rather than LDL cholesterol. Mechanicalistically, they activate the PPAR alpha, a nuclear transcription factor that regulates lipid metabolism. Activation of this increases lipoprotein lipase activity, which enhances triglyceride clearance from the bloodstream. Because of their mechanism, fibric acid derivatives are primarily used in hypertriglyceridemia rather than isolated LDL elevation. They are also administered orally. The most important adverse effect is myopathy, particularly when combined with statins. When used together, the risk of muscle toxicity also increases, so you have to monitor, and making sure to warn the patients about this risk is important. So again, continuing with our theme of distinction, remembering that statins are primarily lowering LDL, fibrates primarily lower triglycerides. So when triglycerides are markedly elevated, this class becomes clinically relevant. Niacin, also known as vitamin B3, affects lipid metabolism primarily by decreasing VLDL synthesis in the liver. Since LDL is derived from VLDL, reducing VLDL production can lead to reduction in LDL as well. Niacin can also increase HDL levels, which historically made it attractive in mixed dyslipidemia. It is still primarily used in mixed dyslipidemia where multiple lipid parameters are abnormal. However, its clinical use has declined due to tolerability issues and the lack of strong outcome benefit compared to statins. The most common adverse effect is flushing, which is prostaglandin-mediated vasodilation. This is pretty uncomfortable for patients and is a frequent reason that patients will discontinue. Hyperglycemia can also occur, which is particularly relevant in patients with diabetes or insulin resistance. So our key distinction here is that niacin modifies multiple lipid parameters, but does not carry the same strength of mortality benefit as statins. So fish oil and plant sterols are considered adjunctive lipid-lowering therapies. The primary effect for these agents is reduction in triglycerides. Fish oil, particularly omega-3 fatty acids, reduces hepatic triglyceride synthesis and increases triglyceride clearance. They may produce a mild LDL reduction, although this effect is going to be much less pronounced than statins or other primary lipid-lowering agents. These agents are generally going to be used as adjuncts rather than first-line treatment. They are added when additional triglyceride lowering is needed or when the patient is seeking supplemental approaches alongside maybe a dietary therapy. From a clinical perspective, these agents do not replace statins for ASCVD risk reduction, and that is very important. Their role is supportive, particularly in hypertriglyceridemia. So again, our key point is hierarchy. Statins are foundational for ASCVD risk reduction. Other lipid agents, including fish oil, plant sterols, are adjunctive depending on the lipid profile. Okay, so for this slide, we want to revisit the first-line pharmacologic treatment for hypertension. So now that we know our classes and we have an understanding of how they work mechanicalistically, we want to remember that our major first-line classes are going to include thiazide diuretics, ACE inhibitors, ARBs, and calcium channel blockers. And these classes have strong outcome data demonstrating reduction in cardiovascular events, which is why they remain first line. However, anytime we pick a medication, it is never one size fits all. So what you want to do when you're picking hypertension medication is consider your comorbid conditions. So for example, in chronic kidney disease, particularly with proteinuria, ACE inhibitors and ARBs are often preferred because of the renal protective effects. In diabetes, RAAS blockade is often beneficial for similar reasons. Race can also influence pharmacologic response patterns, so patients may have different average responses to certain drug classes, and the risk of adverse effects such as ACE inhibitor-induced angioedema may vary. So a key clinical skill is not memorizing a list, but integrating patient comorbidities into medication selection. So when you see a patient with hypertension, you're going to ask what comorbidities does this patient have and which class of medication is going to offer additional benefit beyond just blood pressure lowering. Okay, so now we want to summarize those lipid management principles at the high level. So high intensity statins are indicated in patients with established atherosclerotic cardiovascular disease. These patients already have clinical ASCVD, so the goal is secondary prevention, that is reducing the risk of recurrent events. High intensity statins are also used in patients who are considered high risk based on overall cardiovascular risk assessment. Moderate intensity statins are generally used in patients with intermediate risk. So in these patients, the goal is primary prevention, which is preventing the first cardiovascular event. The key concept is that lipid therapy is risk-based, not numbers-based. So the goal is risk reduction, specifically reduction of future myocardial infarction, stroke, or cardiovascular mortality. From a pharmacologic perspective, statins are the anchor therapy. So other agents are considered adjunctive depending on the lipid level and the overall risk profile. So when you see a lipid question, think in terms of primary versus secondary prevention, overall ASCVD risk, and appropriate statin intensity. So as always, our geriatric patients are going to require careful consideration. First, reduced renal clearance is common with aging. Many of our cardiovascular medications, including ACE inhibitors, ARBs, and diuretics, rely on renal function for elimination or significantly affect renal hemodynamics. So even modest reduction in kidney function can alter drug levels or increase the risk of adverse effects. Secondary, there is an increased orthostatic risk. Our older adults are more susceptible to orthostatic hypotension, especially when treated with diuretics, alpha blockers, vasodilators, or other antihypertensive. So falls and syncope are a major concern in this population. Third, polypharmacy we know is common. So drug-drug interactions and cumulative adverse effects become more likely as medication lists grow. Because of these factors, monitoring is critical. Electrolyte and renal function should be assessed closely, particularly after you initiate or adjust a diuretic or a renin-angiotensin-aldosterone system blocking agent. Clinically, when treating hypertension in older adults, the goal is not simply aggressive blood pressure lowering. It is safe, individualized risk reduction while minimizing your adverse effects. Okay, so giving a little more detail on the importance of considering race-related pharmacologic response. First, there can be variable blood pressure response patterns among different populations. Some patients have demonstrated different average responses to certain antihypertensive classes, and that reinforces the importance of individualized therapy and reassessment after medication initiation. Secondary, there is an increased risk of ACE inhibitor-induced angioedema in certain populations. While angioedema is rare overall, recognizing that different risk is important when selecting RAAS blocking agents. And then third, our social determinants of health are of course going to affect our adherence. So medication access, affordability, health literacy, and trust, all of these are going to influence whether a particular therapy is taken consistently and effectively. It's important to emphasize that race and social construct is not a biological determinant of drug metabolism in isolation. So clinical decisions should always be individualized rather than based on large demographic categories. So as always, patient education we know is critically important. For hypertension, patients should be instructed on proper home blood pressure monitoring. This allows for accurate assessment of blood pressure control and helps guide therapy adjustments. It's also important for patients to be very engaged in their care. Orthostatic precautions are particularly important in patients taking diuretics, alpha blockers, vasodilators, or if they're on multiple antihypertensive agents simultaneously. Patients should be advised to stand up slowly from sitting, especially when they first begin an antihypertensive therapy, and also get up slowly from a lying position, and that helps reduce the risk of dizziness or falls. For statins, patients should be instructed to report muscle pain. While myopathy is uncommon, early recognition is important to prevent adverse effects. They should also understand that mild muscle soreness does not always require discontinuation, but persistent and severe symptoms warrants evaluation with the provider. And then, of course, adherence is critical. Lipid-lowering therapy reduces the long-term cardiovascular risk, but only if taken consistently. So patients often, again, feel no benefit, they don't feel any symptoms, and so reinforcing the preventive purpose of a statin is essential. So this slide just emphasizes some of the professional responsibility that we have in pharmacologic management. First, you always want to confirm the indication. Every medication prescribed should have a clear documented rationale. So in cardiovascular pharmacology, that means identifying whether the goal is blood pressure control, rate control, volume management, or ASCVD risk reduction. Second, you want to make sure you're screening contraindications before initiating therapy. For example, we need to avoid ACE inhibitors in pregnancy, avoid non-selective beta blockers in severe asthma, avoid non-dihydropyridine calcium channel blockers in heart failure with reduced ejection fraction. This step is going to help us prevent predictable harm. Third, we want to monitor for our adverse effects. So this includes checking electrolytes with diuretics, monitoring renal function in RAAS blockers, and assessing for muscle symptoms with statins. And then, as we always say, we need to make sure to document clearly. Documentation should reflect our clinical reasoning, the indication, the risk assessment, and the monitoring plan. Okay, so some quick high yield takeaways. First, our RAAS blockade reduces mortality. So this is our ACE inhibitors and ARBs. They are not just blood pressure medications. They provide cardiovascular and renal protection and improve outcomes in heart failure and post-MI patients. Very, very important. Secondly, our thiazides are first line in many patients with uncomplicated hypertension. They have a strong outcome data and remain foundational in guideline-based therapy. Third, our statins reduce ASCVD risk and events. They are the cornerstone of lipid management and are the only lipid-lowering class on the list that has a strong mortality benefit. Fourth, remember that dopamine is dose dependent. Its receptor activity changes with the dose, making it, it's a classic pharmacology exam concept, and it reinforces adrenergic physiology. Finally, nitrates are going to reduce preload. Their primary effect is venodilation, making them central in angina management and useful in certain hypertensive emergencies. So we will continue to discuss these classes as they are used multiple times in different cardiovascular scenarios. But I think if you understand these core principles, it will help you understand the foundation of cardiovascular pharmacology as we move through the additional weeks and lectures.